Hello, everyone. My name is Sierra Cathell, and I will be teaching you about pediatric airways and asthma. So to start, these are the differences between the pediatric airway and the adult airway. So pediatric airways are very short and narrow, which causes a lot of swelling and edema. And then they also have a really large tongue, which also can occlude the airway, which does not help with getting air into the lungs when they are experiencing any kind of airway obstruction. They also have a very large prominent occiput, which is the back of their head. So when they're laying down, it puts them in a flexion position. So this also, if you think about it, like your neck is going down. So it also occludes the airway and does not help airway reach the lungs. They do have short and concave vocal cords. Their cricoid is the smallest part of the airway. They do have soft cartilage, so it moves all over the place and is very hard to control. And they don't have a developed lower airway yet. For the adult airway, they have the flat occiput, so it doesn't like flex their chin to their neck so that they can still get air in. They have a smaller tongue. They have horizontal vocal cords. Their vocal cords are small in diameter. They do have the firmer cartilage, and they do have a larger lower airway. So asthma is a chronic reversible obstructive airway disease that is caused by the spasm of bronchial tubes. So if you saw my picture before on the beginning slide, when you have asthma, instead of your airways being nice and open, they actually get very inflamed and swollen with, it can be mucus, just edema or inflammation as well. So when someone is experiencing an asthma attack, you can assess for a cough. They're going to have difficulty breathing, which is dyspnea, because they don't have nice big airways for all the air and gas exchange. They could become hypoxic, which increases the sweating and the anxiety. They can't get enough oxygen into their lungs, so then they can become hyperventilative. They do have wheezing. It's a lower airway obstruction, and with wheezing comes the lower airway. Because of the hypoxia, they could have decreased O2 stats, so they might be put on oxygen. And then we do see a lot of accessory muscle use, such as the nasal flaring, so that you can get more air into your lungs, and then the chest retraction as well. So with mild asthma, it is normally twice a week with flare-ups. This is how they typically diagnose it, with how many attacks you have a week. So moderate is every day, but only happens one time a day. And then severe asthma is several times a day, even when you do take your medication, and I'll explain your medication later in this slide. So for labs, they do your ABGs just to monitor your acid-base balances, and then they can do a CBC to check like your white blood cells if an infection is suspected. So for your diagnostic testing, we do a pulmonary function test. So for this, we want to wear loose clothing. We don't want anything too tight that restricts our lung capacity breathing. You don't want to eat large meals, because I'm pretty sure everybody knows once you eat large meals, you feel so full and bloated and it's hard for you to breathe. And then this test measures how much nitric oxide is exhaled. So high levels of this means that your airways get really inflamed, which causes the asthma. And then that's how they diagnose you and can get the correct medication and everything that you need to control your asthma. So they also do skin prick testing. As you can tell by this picture, they inject the allergen under the skin, and then if you create that bump on your skin, that means that you're allergic to it. So they do it like in an order that they know which is what, and then that's how they diagnose you. So your medications. So we have a whole bunch of them. Your short-acting beta-2 agonists, these are going to be your rescue drugs for acute attacks. So if you're out and say you come in contact with a dog, this is what you would use as a rescue drug. So these are albuterol. Albuterol is a bronchodilator, so it helps increase your bronchioles to allow more air into your lungs. They're going to be used for flare-ups in case you come in contact with one of your allergens. Racemic epi is also a bronchodilator. These are used for your upper airway obstructions, and they're going to be temporary relief of your symptoms. So those ones are definitely your rescue drugs. Always carry them if you have asthma because it could happen at any point and you want to make sure that you're prepared. Corticosteroids. You want to take these for 3 to 10 days and then rinse your mouth out after use. So prednisone is going to be taken in high doses for a few days. You don't want to take them on a long-term basis because steroids can become addictive. And then you also want to know your side effects with the short-term steroid uses. So Flovent is a long-term treatment. It is not going to be used to replace a rescue inhaler or relieve sudden breathing problems. This is going to be one that you are going to be on for a long time. If you do have an attack, it's not what you're going to use as a rescue. It's one that if you feel one coming, you could use it before it gets worse. So some more medications. We have anticholinergics, which is otropium and Atrovent. These relieve acute bronchospasms, and it's also not a first-line bronchodilator. And then you have your leukotriene receptor agonists. These are Singular and Montelukast. And these are used to help decrease the amount of allergic reactions that you do have. And then you have your long-acting beta-2 agonists. These are Atavir and salmeterol. You want to use these to prevent and reduce the use of the short-acting inhalers because you don't want to constantly be taking your short-acting ones. You want to be able to manage your asthma and not have attacks constantly. You want to give it with an anti-inflammatory, excuse me. And like I said, you don't want to use it as a rescue medication. Excuse me. So for your teaching, you definitely want to teach your patient to avoid their triggers. So our intrinsic are the ones that come naturally. It's the smoke, it's the exercise, it's gas and fumes and weather changes. And then extrinsic is not going to be something that's part of essential nature, and it's going to be your actual allergens. So your house dust, your cat and dog hair, your mold and pollen. These are the ones that will cause an allergic reaction immediately. So you want to teach about your short-acting inhalers like the albuterol and the racemic epi. You want to make sure that you have them, and you don't want to use them constantly. You want to be able to manage your asthma. So the use of a spacer. So a spacer is added on to the tip of your inhaler. So it's the inhaler and then the little tip that normally goes in your mouth, but instead there's going to be a spacer on it. The spacer allows the medication to go deeper into your lungs. So like you would pump the inhaler, it would go into the spacer, and then you would breathe in the spacer air instead of right out of the inhaler so that it doesn't get stuck like in the back of your throat. So you want to prevent exposure to secondhand smoke. Secondhand smoke can increase the reaction of your lungs to have an attack. It constricts your airway, and it's just not good if you do have asthma. And then your collaboration team can come up with an asthma action plan, and I will go over that a little bit later. So collaboration. You could have your primary care physician. So this is the person where if you're not really sure why you're having these attacks, you can go there, they can diagnose you, and then they can refer you to more experienced people with the asthma, such as an allergist or immunologist. These people identify the triggers and they create your asthma action plan. So they would actually do the ones that put the allergen under the skin and see what you're allergic to. And then a pharmacist, obviously, they're going to give you your medication. They're going to keep you up to date on all of the questions and side effects that you could experience with them. And then a pulmonologist is just someone that your primary care could recommend to you if your asthma is complicated, difficult, or severe, because severe asthma is very life-threatening if you don't have the right medication near you, or if someone around you doesn't know how to treat your attack or anything like that. So our goals. We want to reduce the number of attacks. So education is very important. You want to make sure that they know what their triggers are. You want to make sure they know how to use their rescue inhalers. You want to make sure that they know the ways to decrease using them. So such as reducing the amount of triggers that you come in contact with or stuff like that, so that they're not prone to just constantly using their short-acting inhalers. We want to make sure that our kiddos can play normal in school and have regular school attendance. We don't want them constantly to be out at recess and have to miss that because they need to go into the nurse and use their inhalers. And then we don't want to have any nighttime coughs either that disrupts their sleep schedule. We have to use their inhalers again, or anything that could affect their airway. So I do have a video on an asthma action plan that I'm going to play for you all. Well, I don't know if it's going to work. So I have it linked into my PowerPoint if you want to watch it or not. But for now, I will just go over an asthma action plan. So these are something that you can give with your doctor. This is also my other template thing for my project. So you would fill out like their name, their doctor, and all of their information up here. So for the green, this could be like your rescue inhaler, right? So they would put the medication, how much you want to take, and how often you need it. So green, it means your breathing is good. You don't really have a cough or a wheeze. You can sleep through the night. You can still work and play, but this is so that if for some reason you do come in contact with something, you're able to, excuse me, sorry. You're able to have the medication ready and know how to use it. Caution is yellow. So you're going to list the medications as well. This is exposure to your known trigger. This is when you start to have a cough and a tight chest. You could start having a wheeze or a cough at night. So you can add this to the green in case your asthma gets worse. And then red is danger. So this is when these medications above are not working. You're breathing really heavy and fast. Your nose is opening wide, so we're using accessory muscles, so nasal flaring, your ribs, the retraction are showing, and you can't talk well, so you're really struggling to get air in. This is where they would put the medication that you would use for that. So for kiddos that are in school, the nurses would have this, your doctor's offices would have this, parents would have this, so that whenever an attack occurs, we know how to use it. And that will be the end of my presentation. So thank you very much.